Welcome back to The Explainer. Today, we're diving into something that is, quite literally, a matter of life and death: sepsis. We're going to break down the massive global stakes of this condition and then unpack the newly updated life-saving 2026 Surviving Sepsis Campaign clinical guidelines. Whether you're a healthcare professional, a medical student, or just someone who loves understanding how emergency medicine works, this explainer is absolutely going to change how you view medical response.
Okay, so here's our roadmap for today. 1. Sepsis as a global crisis. 2. The neonatal burden in Nepal. 3. The 2026 guidelines on early recognition. 4. The 1-hour antibiotic window. And finally, 5. Hemodynamic targets and resuscitation.
Let's jump right into part 1. Sepsis, a global crisis.
49 million. Pause and think about that for a second. That's the approximate number of global adult cases of sepsis every single year. Sepsis, which is basically a life-threatening organ dysfunction caused by the body's extreme response to an infection, is happening on a scale that's almost hard to wrap your head around. It's everywhere in literally every healthcare system in the world.
Now, contrast that with this number: 13 million. 13 million sepsis-related deaths happen annually. That really puts the incredibly high stakes into perspective, right? A huge fraction of people who develop sepsis just don't survive it, and many who do are left with long-term physical and cognitive challenges. This is exactly why the guidelines we're about to cover matter so intensely.
Which brings us to Section 2, the neonatal burden in Nepal.
Zooming in on a specific, highly vulnerable demographic, neonatal sepsis in Nepal remains a heartbreaking killer. National data actually shows that sepsis contributes to between 20 and 26% of all neonatal mortality there. That means up to a quarter of all newborn deaths in this region are tied directly to these severe systemic infections happening right in the first 28 days of life.
Now, if we track the overall neonatal mortality rate from 2010 to 2022, there's definitely some good news. The rate in Nepal has successfully declined to 21 per 1,000 live births, which kind of mirrors the general improvements we're seeing across South Asia. But despite those vital improvements in neonatal healthcare, the specific burden of sepsis remains disproportionately high. It's a really stubborn, lethal problem.
So why is this still happening at such high rates? Well, in rural Nepal, about 35% of deliveries still happen at home, often without skilled birth attendants. And that doesn't just endanger the infant. It puts mothers at immense risks too, with preparis sepsis showing a 7.5% prevalence among pregnant women in rural areas. When you combine traditional practices like unsterilized cord cutting with a 12% rate of low birth weight and preterm births, you end up with highly vulnerable newborns with immature immune systems facing massive environmental risks.
Let's pivot from the problem to the solutions in Section 3, 2026 Guidelines and Early Recognition.
Here's the million-dollar question. How do we catch sepsis before the patient even reaches the hospital doors? It's incredibly difficult, especially when surveys show that knowledge levels among medical officers can be suboptimal, averaging only about 48% correct on sepsis protocols. That knowledge gap actually sparked one of the most vital updates in the new 2026 guidelines.
The 2026 guidelines now officially suggest using a standard sepsis screening tool right in the ambulance or during a medical flight. Why? Because roughly half of all patients hospitalized for sepsis arrive via emergency medical services. By screening en route, paramedics can alert the hospital before they even arrive, kickstarting that diagnostic momentum. It's all about beating the clock. Next up, Section 4, the 1-hour antibiotic window. Time is quite literally tissue here. The 2026 antimicrobial timing framework categorizes patients down 2 distinct pathways. Is shock present or is shock absent? And from there, it evaluates the likelihood of sepsis. Is it definite, probable, or merely possible? Breaking it down this way gives clinicians a direct, split-second guide on exactly how fast they need to move with antimicrobial therapy.
Here's the core takeaway. If shock is present or if sepsis is definite or probable, the recommendation is absolute. You must administer antimicrobial therapy immediately, ideally within a strict 1-hour window. But if you've got a possible sepsis case without shock, where the bacterial infection isn't quite clear yet, the guidelines give you a rapid 3-hour window to investigate infectious versus non-infectious causes. It's a really smart balance of aggressive treatment and responsible antibiotic stewardship.
Finally, we have Section 5, hemodynamic targets and resuscitation. Once sepsis sits in, restoring blood flow is critical. The resuscitation guide emphasizes immediate, ongoing monitoring.
Within the first 3 hours, the first-line intervention is fluid resuscitation, specifically giving at least 30 milliliters per kilogram of IV crystalloids, basically standard IV fluids. If the patient's blood pressure stays dangerously low after that, you bring in vasoactive agents, initiating norepinephrine as the absolute first-line vasopressor to squeeze the blood vessels and bump that pressure back up. But here is a fascinating new update for 2026 that you really need to know. Historically, the standard practice is to use those vasopressors to target a mean arterial pressure, or MAP, of 65, and that's still the recommendation for most adults. But for adults age 65 and older, the guidelines now actually suggest permissive hypotension. That means aiming for a slightly lower MAP target range of 60 to 65. Recent trials showed that reducing older patients' exposure to vasopressors to hit this lower target was actually associated with reduced mortality. It is a brilliant example of how tailored medicine is constantly evolving. We've covered a lot today, from the immense global burden to the razor-sharp precision of the 2026 guidelines. But I want to leave you with this final provocative thought. Can global healthcare systems successfully implement these universal, high-tech guidelines across both well-funded hospitals and the ground realities of low-resource settings like the rural areas of Nepal we looked at earlier? The science is incredibly clear on how to survive sepsis, but the ultimate challenge is making sure everyone, everywhere, gets access to that life-saving 1-hour window. Thanks so much for joining me on The Explainer today. Stay curious, stay informed, and I'll see you next time.